Hi, this is a case of congenital lamellar cataract in 6 years old female child who presented to me with her parents complain of that their daughter is squeezing her eyes while watching TV. Her ocular examination revealed bilateral congenital lamellar cataract. As it's clear, it is the same picture in both eyes, and the plan for this patient was to do phacoemulsification with IOL implantation and optic capture through the posterior curvilinear capsulorhexis. I started the surgery with 2.4 clear corneal incision, then doing the anterior capsulorhexis and hydrodissection, and just doing aspiration by the phaco probe and then cleaning the cortex with bimanual irrigation aspiration. The most important issues in congenital cataract that the elasticity of the anterior capsule. So when you are doing the anterior rhexis, you should be notice that there is a propensity for this rhexis to extend to the periphery. Here you can see I am using the cystatome to create a small flap in the posterior capsule. Then using the rhexis forceps to complete the posterior curvilinear capsulorhexis, as it's clear. While doing this step, it is important to fill the anterior chamber and the capsular bag with the viscoelastic material, and always start with small rhexis, as the elasticity of the capsule will make it larger than your plan. For example, if your rhexis will be 5 mm, start to do a 4 mm rhexis. Now I complete the posterior curvilinear capsulorhexis. Now after doing the posterior capsulorhexis, I want to implant 3 pieces hydrophobic IOL. The haptics will be inside the capsular bag, and the optic will be captured through the posterior curvilinear capsulorhexis. Now I just enlarge the phaco incision, then implanting the 3 pieces hydrophobic IOL. You can see here I'm trying to adjust the haptics inside the capsular bag. Now I'm rotating the IOL. Now both haptics inside the capsular bag. Now then capturing the optic with the posterior capsulorhexis. The benefit of this technique is to prevent the posterior opacification after the cataract surgery in children. Here it's clear the optic captured through the posterior curvilinear capsulorhexis, and both haptics are inside the capsular bag. Then removing the viscoelastic from the anterior chamber using the bimanual irrigation aspiration. You can see the IOL is stable. Then injecting myocol and doing stromal hydration for the paracentesis. I prefer to take a Vicryl 10O suture through the main phaco incision in the children cases. Then testing the leak and injecting intracameral antibiotic, and thank you for watching this video.